All right. Hello and welcome back. I'm Erik Sunset, your host of the DocBuddy Journal. Here at DocBuddy, of course, we deliver healthcare solutions that take the pain and cost out of broken workflows, like with OpNote, which gives ASCs the power of instantly generated operative reports approved from the point of care. You can learn more about OpNote and all of our solutions at DocBuddy.com. And today we're joined by Eric Passon. Eric is the founder and CEO of Ancore Health. Eric, thanks so much for joining us.
Thanks for having me. I really appreciate it, Eric, with a K.
Yeah, it's going to be fun. Yeah, great name. We can agree to disagree on the spelling. Can't really lose with a name like Eric. And before we get into sort of the meat and potatoes of the show, what else should listeners know about you and your work at Ancore Health?
Yeah, great question. We're a niche consulting firm serving medical groups across the country. We work with health systems, independent medical groups, and corporate entities. And our sole focus is helping them become high performing, and really, bringing physicians back to the business table and doing that blocking and tackling really well and ensuring there's strong alignment between the financials and the mission of the organization.
Yeah, and the blocking and tackling obviously fundamental to the successful operation of any business. Obviously, providers go into the field to treat patients, but you don't get to remain an independent physician for long if your fundamentals aren't sound operating an actual business. So I know one of the things we wanted to cover today, Eric, was the shift from 2024 over to 2025. A lot of factors there. Obviously, recently released CMS final payment rules for the year, which maybe not so recent now that we're in February, but that's news. We have a new administration in the White House. What are you seeing as some of the big deltas from 2024 over to 2025?
Yeah, we're seeing a lot of, obviously, with the new administration, there's maximum uncertainty in terms of what might happen into the future. You noted something that is happening, which is another cut to the fee schedule. It's been a roughly 30% cut over the last 10 or so years. And that's been a death of 1,000 cuts for independent medical groups, which has driven physicians into health system employment models or private equity, depending on their specialty. And the future has a lot of uncertainty as it relates to things like site neutrality, 340B reform, CON laws, Medicaid cuts, and things of that nature. And with a lot of our clients, the focus, coming out of COVID, where maybe volume has picked back up, and maybe we're getting to a place where we can focus on growth and strategy into the future, is how do we optimize our existing physician network, and how do we deal with this changing workforce, especially the different generations of physicians that are a part of our medical group now. We have certain older physicians that were in private practice and sort of understand some of these economic factors affecting the financial sustainability of the practice. But then you have newer physicians that have never been in private practice, maybe looking for more work-life balance opportunities, if you will, that also have to be brought along to understand these changing dynamics. So I feel like a lot of our time is spent really getting physician leaders and administrators on the same page around what does success mean, and how can we drive towards that vision in a way that's aligned with the mission statement on the website.
Well, you mentioned one of the dog whistles for me, which is COVID. And this is kind of a long walk for a short drink of water. But when you look at all of the surveys, all the reporting across the board, pick your source. But pre-COVID, one of the core drivers of physician burnout, and the end result of burnout could be a lot of things. It could be selling the practice and going the employed route. It could be leaving the field altogether. But the prime driver of burnout pre-COVID was a lack of autonomy. It was bad software that the government says that you need to use or you'll be reimbursed less through Medicare. But post-COVID, it really revolves around staffing. And you still have the other factors as well: lack of autonomy, too much paperwork, too much administration, if you will. So as you are combing through the fundamentals with your clients and with the broader marketplace, How does that lack of staffing, like that lack of ability to just make a hire, forget about a great hire or even a good hire, but how are you navigating that?
It's another good question. Staffing's twofold issue. One is the actual cost has increased since COVID. Labor cost has increased in addition to, finding the right people. A lot of when we look at, you know, within the same client, we could have practices that are high performing. In other words, the time to access care is short. They've got really strong front end revenue cycle processes. They're efficient, in their patient intake process versus practices that may be underperforming on some of those key metrics. A lot of times it comes down to practice managers that have been in private practice or have business acumen or whatever that may be within the practice itself. So having strong staff that are really understand and have sound fundamentals when it comes to the business processes is everything. And that's where it comes into play of having strong physician leadership, because uh, not every we don't want physicians to become CPAs. They shouldn't have to sort through a bunch of spreadsheets. But the physician leader should have a baseline of understanding of what's going on with the business of the practice that they can then convey to other physicians that are primarily taking care of people.
Well, to go back, I really like the phraseology blocking and tackling. Obviously, you need to have staff to operate like as a baseline requirement. But that physician leadership piece is really interesting. Do you count culture? Because ultimately, culture comes from the top, no matter what organization you're in. Some cultures are better than others. Just that's just how the world works. So, is physician leadership as a part of the culture? Does that qualify as blocking and tackling for the success of a practice, or is that sort of external to it?
Yeah, when we think of the pillars of a high performing medical group, we culture and engagement is its own pillar for a reason. And engagement is not just engaged. A lot of times we think of engagement as patient engagement with the practice itself, but it's physician engagement, it's staff engagement that represent a culture of an organization, which is really something that's tangible if you're in front of it, but it's not tangible in terms of a metric. It's a mindset, and it stems in most cases based on leadership, physician leadership, administrative leadership, cultivating this culture, continuing to communicate, what the purpose of the organization is, and having people feel like they're aligned to that purpose. One thing one of the areas we work on is physician compensation. And, the predominant comp plan across the country is an RVU comp plan, which in essence, pays you for how many, visits or procedures that you do. Inherently, it feels fair because the more I work, the more I'm getting paid on a comp per RVU basis. But it's very much a transactional eat what you kill type of model. And if I pay you, based on how many widgets you produce, that's going to be the currency in which I feel like my self-worth in the organization is tied to. And so that's problematic when you're trying to develop a patient-centric culture within the organization, or a culture that, hey, we're all in this thing together. And so, cultivating that culture is strong physician leadership, having aligned incentives, having an administrative team that is supporting you and you feel supported from that perspective.
I want to put a bookmark in value-based care in that discussion or that discourse around RVUs being the part of the incentive chain. But before we get there, what are some of the other pillars that drive successful operations?
Well, we talked about culture, obviously operational excellence. So having the, standards in place for all the blocking and tackling things that I think we touched on before: revenue cycle management, patient access, the clinical workflows. Do we have, if we go into one of our clinics as a patient, do we have the same feeling when we go to a different clinic across town that's a part of the same organization? Um, organizational leadership and management is a key one, where we have a structure that allows for physician leadership to have a seat at the table for business decisions, and we have strong alignment from that perspective. Um, and some of the others are get into, compliance, obviously, as you're in healthcare and as you're working with medical groups, being compliant across the board, not just HIPAA compliance, but we've got coding compliance and so forth, is a pretty important component of the model. Um, and then being transparent. So as it relates to reporting, for example, that we see with high performing medical groups. Not many medical groups do this, but they're unblinded in performance metrics. So for those measures of success of the organization, Dr. X and Dr. Y can see each other's performance, and that helps to elevate um, the performance of the overall organization when you have that level of transparency. And it also signals that there's no or very limited special deals as a result. And as soon as you have special deals happening outside of your existing structure, that sort of um, also sort of becomes disconnected from the purpose or from building the culture that you want within the organization.
So that gamification of performance, that's kind of an outdated term now. I think transparency is better. I like leaderboard. Maybe I'm old fashioned. Just show me the leaderboard. I don't need to
Yep.
gamify it. Where do I stand? Is that data that you're able to get out of, say, a PM or EHR? Is that a dashboard that you provide? Where does that come from? Because some of these softwares in use are much better than others at reporting and analytics like that.
Yeah. Good question. And you would think in this day and age, there's been so much advancements in technology that it's still really hard because of the number of different systems in place to create a single source of truth. We see with many of our clients that, if you run the report this way versus that way, you get different numbers. And then that sort of also impacts culture if you are transparent and the numbers aren't accurate or they're perceived not to be accurate. And physicians are skeptical people, so they should, they need to be vetted. The data should be vetted. So I think it starts with, do you have a single source of truth? So your PM system, if you have third-party claims data, if you have GL, payroll, scheduling, referral data, is it all coming into a single source of truth? Do you have a structured cascading management reporting from the executive level all the way down to where your individual practices and individual physicians are all singing from the same sheet of music, which I'm making it sound very easy, and it's not, to do that well. But I think that's a strong starting place, because if you don't have that single source of truth, and this is what we tell our clients, is perception rules. If I can poke holes in the data that you're sharing, or there is no data and transparency within the organization, then I'm going to make up my version of the truth based on how I feel and what I see and touch from that perspective. And so really, I think our greatest value is sort of sorting through uh, and bridging that gap between perception and reality.
Yeah, how I feel versus this is what the data says are often very different. Very infrequently will those two things line up. I'm sure I'm preaching to the choir there.
Absolutely.
So with the bookmark, we put in RVUs and value based care, and to an extent culture. If the ultimate is not generating as many RVUs as I possibly can, because that really doesn't take into account quality of care. That's just it's a tally, it's a number. Not to say that the care being provided isn't great, but it's just a bottom line type of exercise, maybe a top line type of exercise. So I guess let's unpack this a little bit. With regard to culture and a shift away from just a pure widget production line, as you put it, but RVUs are how we're compensating physicians. What's the balancing act that's in play?
Yeah. So I think, and this is a question we get from our clients all the time. And I think we have a blog post that says, sorry, there is no magic formula. Our medical groups, health systems have been wrestling with physician comp since uh, since the beginning of time. And and what that tells me is that, yes, if all I have is compensation and all I have is worked RVUs, then I've got a transactional relationship with my individual providers, and that's a problem, and that's disconnected from the mission statement on the website. I think what a lot of medical groups and health systems have an opportunity to do, that is much more hopeful and optimistic, is that we have this ability right now to basically try to connect them back to that mission statement on the website. We have the ability to help educate our provider base around what financial sustainability means, not just RVUs. I mean, production is important, right? We need access to care. We need to be able to see the community that we're serving, but we also, to your point, need to provide high quality care. We need to be really intentional about what setting they are in, and can they be seen in an office or at home, or should it be an ASC or a hospital? And those decisions, making those very intentionally, are all really important. And so many times we get approached to change the comp plan because physicians aren't behaving the way they want them to be. And most of the time, it's not a comp plan issue. It's a leadership issue. It's a transparency issue. It's a culture issue. And that many organizations should use this opportunity, especially now in this time of uncertainty, to take a step back and affirm their purpose, help the physicians, practice managers understand their purpose, and work on, you know, aligning incentives and the blocking and tackling in a way that's more strategic in nature. A lot of these groups were formed out of necessity, right? Because it was tough to stay in private practice. Then we moved on to, now either Epic or Cerner EMRs for meaningful use purposes. And, we're typically, many of our clients are living off of single digit margins. So they're surviving the day. I think, I think it's time for them to take a step back and say, hey, we've built this amazing network of providers. How do we really think about using that network for a purpose that's more aligned with our mission?
Well, without giving away the secret formula, how do you do it?
It's a good question. Um, there's not a step-by-step guide, unfortunately, and for the fact that similarly that there is no magic formula on the comp plan. I think each organization's sort of in a different place of that journey. And so, depending on where they are, step one, is can everyone within the organization articulate the purpose of the medical group and in a way that's consistent and makes sense? That's pretty simple, right? You would think, oh yeah, we understand the purpose of the medical group. You would be amazed that if I talk to the CEO of the medical group and the CMO and the CFO, and then talk to a practice manager or a regional physician leader, I would probably get 5 or 6 different answers to that question. And so that's a real simple place to start. That doesn't, yeah, it feels soft, and it's not about, how much ROI we can generate or how much additional revenue we can generate, but it's an important piece of that culture question that you pressed on earlier.
Well, I think that makes sense. And it's, these things that you can't measure, it's easy to cast aside and go, there's no number that can be assigned to this. It's qualitative, not quantitative, but man, are they important. And you really only find out how important they are when you get them wrong.
Yeah, there's another thing that you made me think of. I think it was a survey by Gerard, um, around the growing distrust between physicians and administration. I think it was a statistic in there around, six of 10 physicians have a favorable view on unionization. And when you peel some of that back, and you see some of this going on, in particular in the Northeast and Boston, you peel some of that back, and yes, some of it's related to burnout, some of it's related to the lack of staffing. But a lot of it is also related to this fear of losing autonomy, the lack of collaboration, the lack of transparency. So I not only, there's uncertainty in terms of regulatory uncertainty, but I also think, being aligned on your purpose as an organization and an individuals within that organization, you end up mitigating these hidden risks that you're not even thinking about, like unionization, for example.
Yeah, that makes sense. I'll have to find a link to that to get it into the show notes. I'm not sure I've seen that one myself, but I probably should have. We put a pin in value based care now for a while. I'm not sure how much there's to say. It kind of diverged from the initial intended talking point, but value based care is a very opaque term. It can mean, just like with the mission statement on a website, you could get a lot of different answers about what actually is value based care. Obviously, there's implications moving from fee for service and the boatload of RVUs that get generated every day, week, month, and year. Value-based care takes a little bit different look at it, though, depending on who you ask, trending more towards patient outcomes and keeping folks as healthy as they possibly can be. Are you seeing any developments as we're a month into 2025 now around value-based care?
It's really it's really interesting you asked that question because I was telling a colleague recently how the tone around value-based care, I want to say over the last 6 months, last year, has completely changed. We've been talking about, prior to starting Ancore Health, uh, 8 years ago, I was part of the advisory board company, and I feel like, I don't know if it's 10, 15, 20 years ago, we talked about the transition from volume to value. And it's really dependent on market, but in certain markets that are predominantly fee for service, in my conversations recently, it feels like we're doubling down on fee for service. Not we, but the providers are. The notion of value-based care is met with a high degree of skepticism in terms of their ability to ever really move the needle, and it's blamed on a lot of different things. Um, in other markets, that's different, right? Depending on the conditions or favorability. Obviously, what's going on the West Coast versus East Coast have been different for a number of years. I also think what's happened to drive that is the changing coding regs, the V28. Uh, the change to V28 really put a hamper on making money from coding, optimizing coding. And so now the ability to make money is tied to reducing total cost of care. And certainly there's opportunity to uh, better manage members, patients that have multiple chronic conditions and behavioral health conditions as well. At the same time, I think, the individual patient and consumer, the door that hasn't been completely unlocked is how do we empower the consumer to manage their own individual health, which I do not have answers for. I apologize, but I think that's really the next step that hopefully we'll go as a society, um, and really start focusing on value-based care initiatives that truly bend the cost curve, that truly meet the goals of the triple aim. And now we're sort of moving beyond just coding as a way of earning dollars.
That patient accountability piece, the providers that I've had on this show or clients, they maybe they don't all say the same thing, but I will do everything I can to make sure this patient gets a great health outcome. But if they're making poor diet choices, poor lifestyle choices,
Mm-hmm.
continuing to smoke, I mean, all of these are low hanging fruit examples. But the providers that I've spoken to about this say, I can do everything possible to change that behavior, but most of the time it doesn't change. People come to me for a quick fix, won't put in the work, whether it's, something as easy as diet and exercise, which maybe isn't necessarily easy, but that's a choice that's made every day. That seems like a big barrier to value based care when the providers are unable to change behavior for somebody that's, on the path to dying an early death.
Yeah. Yeah. And that's not. at least within our company, I wish I could wave a magic wand and solve that particular issue, but it's all the more reason is the quick ways of making money in the past are no longer there, right? There's only these more challenging ways of being financially sustainable, which means going back to where we started, focus on the fundamentals. We need to collect the money we're owed. We need to provide access to patients in the community that in some cases could be taking months before they can make an appointment. Solving those issues are really important because, if we're not seeing the patients, if we're not being proactive around that engagement for those that want to be engaged, it's going to be challenging to get beyond where we are today.
Well, and with that in mind, that brings us back on track here through the lens of 2025, new year, a lot of new things happening. Are there any unique twists this year that your high performing clients are looking at for those fundamentals that maybe hadn't been so obvious in the past?
I think it's interesting. I think what's old is new again. We talked about those pillars of a high performing medical group. There's really when I see the change this year from what they were back in the advisory board days, there were these things called gold books, and they contained a lot of really interesting research from different providers across the country. A lot of those same fundamental elements are still, still attributes of a high performing medical group. Strong physician leadership, the culture engagement we talked about, having a single source of truth, transparency, those sort of things. What's different now, I think, is the advancements in technology, in particular AI. And I'm not going to profess to be an AI expert beyond using ChatGPT, but I do think because of the headwinds that I see from a reimbursement perspective, like the physician fee schedule, or what we talked about before about cost of living in certain markets are astronomical, then how do we find efficiencies within the practice, and really staying on the administrative side? I don't want to wade into the clinical decision making because I think that's a whole nother topic of conversation that's going to have more increased scrutiny and regulation associated with it. But I would encourage every practice to look through workflow by workflow. How could we use technology, in particular AI, to streamline the process, to have our people work at top of license? And I think what you'll see is there's a lot of things that we can be doing more efficiently that's not replacing all this labor cost, because a lot of practices we work with are actually understaffed. So it's
Mm-hmm.
really helping them be more efficient. It's helping to speed up the communication with patients in particular and drive access, right? We can see more patients as a result of having access to ambient AI technology, and now physicians are able to leverage that innovation so they can be more present with the patient, as one example. The thing with AI is it's just there's so many examples. There's so many different workflows. So that's why I think taking a more deliberate approach around that makes a lot of sense. But I think that whether it's 2025 or over the next 3 to 5 years, I think whether it's AI or other forms of technology, finding ways to be more efficient is going to be really important, especially as you have a new age of physicians wanting work-life balance, maybe doesn't, want to be at 20% above the 90th percentile of RVUs. And so how do we continue to drive efficiency within our practices um, to be able to take care of the patients that need to be taken care of?
That's really well put, and this is a little bit of a philosophical point. But when you look at physicians, the C-suite, if it's a big healthcare organization, administrators, nurses, MAs, everybody from top to bottom has a smartphone. I'd bet the house on that. Everybody's got a smartphone. Not that maybe an iPhone or an Android is the height of technology use, but smart TVs that you have apps on. Everybody knows how to get an Amazon Prime subscription. It's not that it's resistance to technology, and certainly there's a factor of being snake bitten by the legacy EHRs, and that was my background. I don't know if we talked about that before recording, but I'm very well versed. There was some really bad software out there, very expensive, and then on top of that, the government is telling you you're going to use it or be reimbursed less.
Hmm.
That's not a formula for success. But when you look at these workflows, still doing manual fax, still handing things off 3 or 4 times to 2 or 3 different people to be processed. And I just heard a horror story from a good friend on the West Coast that they have a single staff member who is both chasing down charts for completion and verifying insurance, and at a tremendous, tremendous cost. There's no throughput on either factor, as you would expect with one person doing both of these jobs. So the philosophical point is that you're surrounded by technology throughout the rest of your life, but then you're relegating yourself to these tragedies of workflows at work. What's going on?
Yeah, I think there's always, in healthcare, there's resistance to change in general. I think culturally as a healthcare, um, I don't know, industry, if you will, there's so many providers that basically they want to know what another provider is doing, and oh, we'll do that thing because they're doing it, so it must be right. And that's where I go back to the fact that each organization is unique. It's got its own purpose, has its own, yeah, there's similarities in terms of systems and so forth. But even systems, you could be on the same system, could be set up completely differently. And we see that when it comes to the back end data piece of it. It's like that's great. We understand how to extract data out of one system, but each client is such a unique setup. And so I think it goes back to that leadership question. And do we have an organization that is has a culture for change or not? And we often talk about, not to keep using buzzwords, but that you have to move at the speed of trust. And so figuring out what that right speed is important, but embracing these changes, I think communicating them in a way that's not, we're not replacing how you deliver care. This isn't about reducing our staff by hundreds of people. This is just about working at top of license so that person that you were describing can be focused on the outliers or the things that may be coming ahead, and not focused on, how do I do all these manual tasks from a week ago, and just working smarter, not harder.
Well, there seems to be a willingness to embrace AI unlike any other health IT previously brought to market. And it's kind of a cruel twist of fate that a lot of these workflows were available to you in the pre AI days, but there was a fear, oh, we don't really want to let any of our staff go. We're happy with all of our FTEs. Like, is this going to cost so and so their job? Like, no, thanks. We'll think about it. But the cruel twist of fate is now, like in your example, we're understaffed, but we're still doing things manually, but there's an even better digital solution available for it. So I'm seeing that people are, or healthcare organizations are much more willing to at least have the conversation around that
Hmm.
change. But the speed of trust is a really good way to frame it.
Yeah, yeah. It should be improving culture, like the ambient AI technology. The technology should be helping to improve culture, improve efficiency. Maybe it's not about, letting a bunch of people go, but maybe we don't have to grow our labor force as much as we think we need to do because, we're leveraging technology in a smarter way. I think the path of least resistance is definitely going to be more on the administrative side of healthcare. That, like I mentioned before, I think the clinical side, I understand why organizations would move with caution around anything dealing with clinical care. But even in those situations, there's ways of using AI not to make the ultimate decision, but to improve the quality of life for the providers.
That's really well put. Before we wrap up, Eric, is there anything we glossed over or anything we didn't cover that we should have?
don't know. We talked about a lot. No, I think there's I guess from my perspective, I'm filled with hope around what the future looks like. I feel like at times you can, especially as a consultant, right? We're often brought into crisis situations or when the sky's falling and we need help. What's really exciting right now is the work that we're doing is for organizations not only that are in those crisis situations, but also organizations that are having some of their best fiscal years and they're taking a step back to say, how can we do that? How can we reimagine our employee medical group for good? And there's, to me, what's different now than the late 90s when health systems back then were in the employment business and then they got out of the business and now they're back into the business is that they have a shot right now to take this network of physicians that they employ and really align them more closely to their secret weapon, which is the mission statement on the website. So we're really excited to work with health systems that want to think differently, independent medical groups, corporate entities that employ physicians that want to think differently. And we think there's an amazing opportunity to not only recruit and retain high quality providers and staff, but in a way that aligns them to the organization and having a shared sense of purpose.
Wow, I'm gonna have a hard time building on that statement. That was awesome. So for these health systems, corporations, listeners in general that would want to get in touch with you, how can they do it? Are you big on any social medias, website? Where can folks find you?
Yeah, I personally am not, but our marketing people are, and it's mainly LinkedIn is our main channel. I think we're on Instagram as well, but mainly LinkedIn. And then you could obviously go to our website, anchorhealth.com, to find out more information.
We'll get links to all those destinations into the show notes. Eric, thanks so much for joining us.
Eric, thank you for your time. I appreciate you having me on. It was a fun discussion.
Absolutely my pleasure. And on behalf of the entire DocBuddy team, I want to thank you for listening. Be sure you're subscribed on Apple Podcasts, Spotify, and YouTube so you always get the newest episodes of the show. And until next time, I'm your host, Eric. Talk soon.